you've got a very interesting abstract here, presentation you're giving tomorrow on the addition of Velcade to CHOP in frontline treatment of elderly patients with mantle cell lymphoma. What's the sort of the key messages from that presentation?
Well, perhaps I have first to say that it's not in addition, but it's substituting vincristine, so which is important for the discussion about the toxicity. So it is a novel combination whereby bortezomib is in place of vincristine in the classical R-CHOP treatment for elderly patients with mantle cell lymphoma. I think the crucial point is that by basically the same toxicity, the outcome is much better with the new combination, including bortezomib, the PFS, the progression-free survival, has improved by about 60% if we look at the data as generated by the Independent Radiological Review Committee. If we consider just the investigator data, the improvement is about 100%. And at this moment in time, it is too early to tell about overall survival because the median follow-up is just 40 months. The curves are still diverging. For the time being, the difference is not yet significant, but my impression is that it will become statistically significant as the follow-up goes on.
I mean, Velcade is clearly an active drug in mantle cell lymphoma, and I often add it to chemotherapy if chemotherapy is not working. And if you look at all the studies where Velcade has been incorporated, it seems to be synergistic. So I'm not really surprised at the outcome of that study. One of the issues is the way the vincristine was, not the vincristine, the Velcade was given. So it was twice a week in a sort of standard myeloma schedule. Do you think, because one of the issues was thrombocytopenia, there was quite a bit of thrombocytopenia in the Velcade containing arm. Do you think the scheduling had something to do with that?
Probably yes. It is true that there was more thrombocytopenia, but there was not more bleeding. So this was asymptomatic thrombocytopenia. Yes, I think that the regimen could be further improved on the one side by using Velcade sub-Q and not IV, which would probably decrease further the overall toxicity. And on the other side, it might be that mainly if you keep also vincristine, to use the weekly instead of the 2 weekly schedule, it could probably further decrease the toxicity. I'm not sure that this is going to change the rate of complete responses, but I think that I know that you have some data, and that to my surprise, it does seem that by adding bortezomib to the classical R-CHOP, still including vincristine, if you use a weekly schedule, this is not increasing the neurotoxicity. I would have expected the contrary.
Yeah, so we did a study which is about to be published in the UK, which was in first relapse mantle cell, and it was CHOP versus CHOP plus Velcade. The rituximab wasn't in there, it's an older study, which showed a survival benefit for the addition of Velcade, which was a big surprise to us, but no additional toxicity. There was slightly more low-grade neurotoxicity, but no significant increase in grade 3 or grade 4 neurotoxicity. So giving it weekly, 1.6, that was IV, and I'm sure if we give it sub-Q, you'd have even less. And so the addition of the Velcade to the vincristine wasn't an issue. I think there was anxieties when this study was started that was going to be a problem, and I'm not sure it is if it's given weekly. But what do you think is the sort of the take-home message then? Do you think this is now, as one would call, the standard of care for older patients?
I think we have still to wait a little bit for the overall survival data to mature, but I think that it could become the new standard for the usual patients with mantle cell lymphoma. I mean, in our studies, the median age was 66, which is the median age of the normal patients with mantle cell lymphoma, which comes to your door. And so I think excluding the 10 to 15% very young patients where you can consider a much more intense treatment, I think in the vast majority of the patients with mantle cell lymphoma, that could become the new standard treatment.
Maybe what people will point to is that the CHOP rituximab with rituximab maintenance gives better results, but of course there was no maintenance in this study, and you would expect maintenance would probably double the PFS. That's what you saw with the CHOP-R study. So that regimen, probably with addition of maintenance, may well be better still.
Yes, I think that maintenance is probably of importance in mantle cell lymphoma. I don't know whether this is for all patients or for the indolent part of mantle cell lymphoma. That might be the part which had more an advantage in the Scandinavian study. But I think that the next question, in my opinion, is then how can we further improve the data, either by adding a maintenance or by including a drug like ibrutinib, which seems to now to be very interesting in the treatment of mantle cell lymphoma.
So that's a perfect introduction to my abstract, which was the long-term toxicity of ibrutinib within the mantle cell lymphoma phase 2 study. So this is looking at the toxicity in patients who've been on the drug long-term now. And although there's no efficacy data in this abstract, just looking at toxicity, it's interesting that in a heavily pre-treated group of patients, half of them were on drug for over a year, and a quarter of patients are still on drug over 2 years. So very well tolerated and still obviously efficacious in a very heavily pre-treated group of patients. So what this abstract does is actually document the toxicity and the side effects that people have had concerns about. I think it's quite reassuring. So diarrhea, for example, when that's presented, you see over 40% of people get diarrhea. And what the abstract actually tells you is that it comes on a median of 8 days and it's gone 5 days later. And that's certainly been my experience. It's very modest. It comes on early and it goes. And if patients stay on the drug, once you get beyond 6 months, these side effects are disappearing. Same with fatigue. These are minor, grade 1, grade 2. They're largely going 3 months, 6 months. What people are concerned about, infections, again, infections are disappearing once you get beyond 6 months, no impact on immunoglobulins.
My main concern would be in the usual population of mantle cell lymphoma. I don't remember the median age in this population. But
it's 68 again,
68
something like that.
My main concern would be in these patients, the bleeding, because all of them take aspirins and
I was coming on to that. So bleeding remains constant, 5%. So risk of serious bleeding, 5%, but it's bruising is what people get, contusion, not active bleeding. 4 patients on that study had subdural hematomas, and that was very early on, and they were all associated with trauma or head injury, falls. And all those patients were either on aspirin or warfarin, mostly on warfarin. And so the decision was taken then that warfarin became a contraindication to the study. But bruising is certainly an issue. About 50% of people get some kind of bruising. And again, that's been my experience, that they're marked bruises, a bit like you see, very elderly patients are often bruise easily. It looks a bit like that. Sometimes it's quite impressive. I had a guy who had some very impressive bruises on his arms, but he was in complete remission. He felt great, he didn't care. So I'm not too worried about that side of things. The one thing you have to remember is not use it with warfarin.
But just warfarin or all kinds of anticoagulants?
Warfarin is what people are is the main issue. On the label in the States it says caution with these agents. It's a balance of risk, I think, with these people. The other thing is to stop the drug a few days before any kind of surgery. That there has been bleeding associated with surgery, so you've got to stop and then restart. Some kind of platelet interaction going on there. So it's an issue, but it's not a major issue. And bruising, just have to warn people that bruising is going to become a potential issue. But it works so well, and patients feel good on it. I mean, I just have to explain, and it's a balance of risk, bruising. Versus very active treatment. And so because what's going to happen next is ibrutinib is going to get incorporated into chemotherapy, and then you wonder if the abstract with Velcade is very quickly going to be superseded by bendamustine rituximab plus ibrutinib, for example, something like that.